like to thank you all for coming out today. So I'd like to welcome our speaker today, Dr. Chad Marion. Dr. Marion is an assistant professor in the Department of Internal Medicine section of Pulmonary Critical Care, Allergy and Immunology here at Wake Forest. He serves as Associate Director of the Adult Cystic Fibrosis Program and the Associate Program Director of the Pulmonary Disease and Critical Care Medicine Fellowship here at Wake Forest as well. He obtained his bachelor's degree from the University of North Carolina at Chapel Hill and his medical degree from Lake Erie College of Osteopathic Medicine. He then completed residency in internal medicine at Cleveland Clinic Foundation in Cleveland, Ohio, and then completed his fellowship in pulmonary disease and critical care medicine at Yale University. At the same time, he got a PhD from Yale in investigative medicine. His main areas of interest are Pseudomonas lung infection, bronchiectasis, non-CF bronchiectasis, and cystic fibrosis. So, on behalf of the Department of Internal Medicine, please join me in welcoming Dr. Marion.
Thanks, Adam, and thanks everybody for coming this morning. Again, I'm Chad Marion, and I really want to talk to you today about some very exciting advancements that have taken place in the care of patients with cystic fibrosis. Here are my disclosures. Today's overview objectives are, one, I would like to briefly go over the care of cystic fibrosis from a historical perspective, and then delve in. That's really going to be a high-level overview, and delve into some of the new medicines that are coming out that modulate the protein that's abnormal in cystic fibrosis, the CFTR, the Cystic Fibrosis Transmembrane Regulator protein, and then introduce our Adult Cystic Fibrosis Center and go over some of our clinical outcomes. And if you're looking for a little more granular presentation about cystic fibrosis, on April the 9th, I'm giving the lecture for the residents, or I'll be talking about standards of care as well as management of acute exacerbations of cystic fibrosis. So I want to start today with this quote from T.E. Lawrence from the 7 Pillars of Wisdom. It reads, "All men dream, but not equal. Those who dream by night in the dusty recesses of their mind wake in the day to find that it was vanity. But the dreamers of the day are dangerous men, for they act on their dreams with open eyes to make them possible." And I want to invite you all to be part of this dream, this adventure that has occurred in the care of cystic fibrosis, because we have made great strides over the past several decades and huge strides over the past 7 years. So, brief historical perspective, I'm going to cover about 150 years in 2 slides. So, in 1838 and 1905, we didn't even know what cystic fibrosis was. There were clinical characterization of patients who developed really intra-abdominal pathologies related to cystic fibrosis in pediatric patients, which were described by, I can never pronounce Carl's last name, but also Dr. Landsteiner. But in 1938, Dr. Anderson, who's actually from Asheville, North Carolina originally, made the first pathologic description of the cystic fibrosis of the pancreas. And that's where the name of cystic fibrosis came from, is the pancreatic abnormalities that we're seeing. And she made the association of these abnormalities in the pancreas with patients who had lung pathology as well as gastrointestinal disease. From that time, 1938 to 1989, there was relative rapid progression in understanding cystic fibrosis. It was found that cystic fibrosis was a monogenetic recessive inheritance. In 1949, 1952, it was found that that protein regulated chloride secretion. And then in 1989, the CFTR gene was fully sequenced, and we identified the first major mutation in cystic fibrosis, the F delta 508 mutation, which is the most common mutation in cystic fibrosis. Now, looking at life expectancy over the past almost 100 years, You see, in the 1930s, patients with cystic fibrosis lived a couple of years. They died as children, mostly from complications of their GI system. But as the discovery that was outlined in the previous slides occurred, we developed various therapies, including treatment of the gastrointestinal abnormalities with pancreatic enzymes and nutritional support, airway clearance, discovery of antibiotics to treat acute exacerbations, the invent of lung transplantation, inhaled therapies such as DNase, as well as inhaled antibiotics for chronic Pseudomonas infection. With all these treatments, we've seen a slow and steady increase in the life expectancy of patients with cystic fibrosis. And in the 2005 CF Registry, the life expectancy was around 35 years at that time. So we went from 2 years old in 1940 to 35 in 2010. So really remarkable advancements, but still not where we want to be in caring for patients with cystic fibrosis. We want them to have a normal quality of life and longevity of life and productive lives as possible. So where are we in 2017? So this data that I'm going to present comes from the CF Foundation Patient Registry. This is data from the 2017 registry. It's the 2017 data because it's a year lag behind before new data is presented. So July of this year, we'll get our 2018 data. This registry began in 1962. There are currently over 25,000 patients who are in this registry. And this registry is a standardized process that captures clinical data from patients with cystic fibrosis so we can monitor our ability to treat this disease over time. One of the most remarkable things that have occurred over the past 20 years that will impact your careers as internal medicine physicians as well as subspecialists as internal medicine physicians is the fact that there are now more adults living with cystic fibrosis than there are children. This transition occurred about 7 years ago. So if you see in 1987, there was only about 30% of the population, which is in blue, that were adult. Green is the pediatric population. The pediatric population has remained total number relatively steady over the past 20 or so years. However, we've seen this increase in the adult population. In 2017, 53.5% of patients are adult patients with cystic fibrosis. So we're going to see many, many more of these patients in our clinics who are not providers of cystic fibrosis care. Now, why are there more adults today than there were 20 years ago? Well, a big part of that deals with their life expectancy is increasing. So you see here in the gray bars, these are the total number of individuals who are alive with cystic fibrosis at different ages. And the yellow line is the cumulative percentage of patients with cystic fibrosis based by age. And you see that 50% of the patients are 18-year-old and over at this point. And the major changes that has occurred within the past 10 years is really in this fourth and fifth decade of life. So patients are living much longer than they had previously. And we actually have patients, close to 100 patients in the United States that are over the age of 70 who have cystic fibrosis. So really remarkable, I think. So why are they living longer? Partly due to decreased mortality. So this is the mortality rate per 100 patients with cystic fibrosis. In 1986, it was around 2.1 per 100 patients. In 2017, we're down to 1.3 or so per 100 patients. Still, the most common cause of death for our patients with cystic fibrosis are pulmonary and cardiopulmonary complications. In 2017, 63% of the patients who died, and there was about almost 300 patients in the United States that died with cystic fibrosis last year. 63% 2 out of 3 of them died related to respiratory or cardiorespiratory complications. Second was related to transplant complications. Patients are also living longer because we're doing more lung transplants. And we're doing lung transplants later in our patients, later in their disease. You see in the blue, again, these are the adults. The green color are pediatric patients. These are the total number of patients that underwent lung transplant. In 1994, we did about 100 lung transplants that year in patients with cystic fibrosis. 2017, 250 total. And you see a steady increase in the number of adults that are receiving lung transplant for their disease. So who's getting transplanted? We see these transplants occurring here. These are the number of individuals based by age. Total patients are gray. The blue are the ones that have received lung transplant. And we're seeing transplants occurring mostly in the 4th and 5th decade of life now, which is a shift from previously when we would see them in their 3rd decade of life. So we're the graphs are shifting to the right for this. And all of these things have led to increased life expectancy in our patients. So far, what I've told you is 150 years of care in cystic fibrosis. We've really made a lot of progress. Much of this deals with early diagnosis, screening of infants for cystic fibrosis, optimization of nutritional status, the invent of multiple therapies of standard of care for cystic fibrosis, and other things that we don't have time to go into today. But what really have we been missing in the care of cystic fibrosis? Really been missing the ability to treat the underlying cause of the disease, the mutation, abnormality of the CFTR protein. So that's what I'd like to talk a little bit about now. Before I talk about these specific therapies, I do need to take a moment to go over a little bit of the basics of CF and of CF classes mutations, so you can understand how these medications are working. And we're getting a little more granular now, so I'm going to try to slow down the pace a little bit. So some of the basics with cystic fibrosis. CF is still the most common life-shortening recessive disease in Caucasians in the world. Worldwide, there's a little over 70,000 patients in 2017 that have cystic fibrosis. Almost 30,000 of those live here in the United States. So we have a large patient population here. When it comes to carriers of a mutation of the CFTR gene, 1 in 28 Caucasians have these, are carriers. So there are several of us probably in this room today that are carriers of this disease, but it's not limited to Caucasians. 1 in 48 Hispanics, 1 in 61 African Americans, and 1 in 88 Asians are also carriers of a mutation. In the United States, 1 CF birth occurs out of every 2,500 births in the United States. And interestingly, we still, even with the advent of early mandated screening for cystic fibrosis at the time of birth, we miss about 10% of cystic fibrosis. And those patients are actually diagnosed as adults. So they're diagnosed in your clinics where physicians are picking up on the clinical characterizations of cystic fibrosis and saying something's not right here and sending them to somebody like myself to do further testing. So important to keep in mind when you're seeing patients, if they have pulmonary sinus disease, malnutrition, and possibly bronchiectasis on imaging, you should think about cystic fibrosis as a possibility. And if you're thinking about that, reach out to me. I'm happy to help work these patients up, or you can send them to our clinic. So the cystic fibrosis transmembrane regulator protein, this is really targeted probably for the medical students and residents because they like to ask these questions on board, so I wanted to give a little bit of board-relevant information. This protein is a chloride channel protein, It regulates the extracellular fluid volume, and it is a member of the ATP binding cassette family, and is found on chromosome 7. Is where it's encoded. And this is a ribbon structure of the protein, and we'll see that this is the area that the protein sits in the membrane. This is the extracellular region, and this is the intracellular region. So with regards to mutations that we see in the United States for the CFTR, there are over 2,000 known genetic variants. Now, not all of these variants cause disease, and still the most common out of these 2,000 is the Delta 508 mutation. These variants are classified based on mechanisms of dysfunction, and there's 6 different classes, which I'm going to go into in the next slide. But what I want to point out in this slide is from this pie graph. You see homozygous Delta 508 class 2 mutations account for 46% of the patients with cystic fibrosis. Patients that have one copy of the Delta 508 with a second mutation accounts for 31%. So combining these two together, that's almost 80% of the patients with cystic fibrosis have at least one copy of Delta 508 mutation. And then there are various other either rare or minimal function mutations that can occur. Now, there are 6 classes of mutations in cystic fibrosis. They're classed 1 through 6. Class 1 is a really difficult one. You make no protein. And if you don't make protein, then we're going to have to think about genetic modifiers for those patients. But 2 through 6 are able to translate protein to some degree. Class 2, where Delta 508 lies, you see that protein is translated, but the three-dimensional structure is unstable. The protein falls apart and goes to the proteasome and is degraded, and the amino acids are recycled. So no protein ever makes it to the cell membrane. The class 3, you make protein, but the channel does not function at all. Class 4, you make appropriate amount of protein, but it's a less efficient channel. Class 5, you make protein, the channel works okay, but you don't make enough of it. And class 6, you make protein, but its structure is unstable and it's rapidly recycled from the cell membrane. So lots of mutations can occur, and they have various degrees of phenotype associated with them based on whether there's any protein at the cell surface and how well that protein functions as a chloride secretor. Do want to remind everybody, although I talk a lot about the pulmonary complications of disease, this is a systemic disease, and it really affects every organ in the body. And this is important as we think about therapies that are being developed and currently being used that are expected to increase life expectancy in our patients, because they're going to be now coming to your clinics for, hopefully, diseases that are related to becoming less young, such as coronary artery disease and other things that we see in older populations. And again, clinical presentations, pulmonary disease manifestations are the most common, followed by gastrointestinal symptoms, and then nasal polyps. So if you see any combination of these things in your patients, you should think about cystic fibrosis, especially to target that 10% that we miss in early diagnosis. All right. So that was a quick run-through on the various classes of CFTR mutations. And now we're going to talk a little bit about current and future therapies for us to be able to modulate this protein in our patients with cystic fibrosis. And this to me is so exciting, and I hope you get a little bit excited about it as well. So when it comes to medications to modulate CFTR, there have been two classes of medications that have been developed. The first class that I'm going to talk about are potentiators. And what potentiators do, these are small molecules that help the efficiency of the channel opening. And I heard a great analogy at one of these CF conferences a couple of years ago. I'm from the country, so I really related to this analogy. If you wanted to move some cattle from one side of a fence to another side of a fence, how you do it? Well, you get that gate, you open it up as wide as you can, and you open it up as long as you can, and you move those cattle right across. And those cattle are essentially the chloride molecules. So what these potentiators function is to make this gating channel bigger and wider for a longer amount of time to allow chloride to move. The first mutation that was targeted with this type of therapy was the G551D, which is a class 3 mutation. Class 3 mutations are the ones where protein is made appropriately, goes to the cell surface, but it doesn't function at all. So the G551D was the first mutation targeted, and the medication that they developed is called Ivacaftor. And they studied, in 2011, the STRIVE study, took patients with the G551D, gave them Ivacaftor or placebo with the primary outcome measurement of change in FEV1. And they found within 2 weeks of starting therapy, patients who were treated with Ivacaftor compared to placebo had about a 10% increase in their FEV1 that was sustained over the 48-week study period. In addition to that, a secondary outcome that was really interesting to everybody was the fact that exacerbation rates decreased by about 50% in this patient population. So not only did we get better lung function, but we were able to decrease the number of exacerbations that were occurring in these patients. And equally as important as exacerbations, patients who were treated with Ivacaftor compared to placebo actually gained on average about 6 pounds. Malnutrition is a huge problem in cystic fibrosis. And if you're losing weight, your lung function's down. If we can maintain nutritional status in these patients, they tend to do better. After this 48-week study, the PERSIST study was performed. It took this trial out to 144 weeks of treatment. All of these measures were sustained throughout that 144 week of treatment. So in 2012, we had our first medication to treat CFTR mutation for the G551D, which is 4% of the population of patients with cystic fibrosis. Small part of the pie, but it was a big step. From 2012 to 2018, an additional 37 mutations have been added to have been found to be responsive to Ivacaftor. So now we can treat 38 mutations total for anyone that is 1 year old or over. So we're starting therapy on patients who are 1 year old that have normal lung function, have normal BMI, and hopefully will live through their teens and their early adulthood life, maintaining those types of numbers. And with this increased mutation responsiveness, covering 13% of the patient population. And everybody can memorize all the genes here that we're treating with Ivacaftor. I put this up here because you're going to see how complex this is all starting to get here soon. But these are the responsive genes that are currently currently approved by the FDA for Ivacaftor. Now, the second class of medications that have been developed are what are called correctors. Correctors are molecules that stabilize that three-dimensional structure of the CFTR and aid in trafficking of the CFTR through the cell to the membrane. So this is attractive for a lot of the mutations that either have unstable protein or they don't make protein that even makes it to the membrane. So if it makes it to the membrane and falls off, it can help stabilize, or it can help the trafficking occur. And I'm using color codes here. So the red in the medication name are the potentiators, and the green are the correctors, because the names sound very similar. So the first combination medication that we have to treat as corrector with a potentiator is Ivacaftor, Ivacaftor. They study this in patients who are homozygous delta 508. So they have 2 copies of the delta 508 mutation versus placebo. They followed these patients for 24 weeks and really focus on the blue line of treatment. These are just 2 different doses. Blue line is the one that's FDA approved versus placebo. And they found FEV1 percentage, there was a modest increase, about 2.8 to 3% increase in FEV1. But their secondary outcome of exacerbations was what really perked everybody's interest, was the fact that there was between 30 and 40% decrease in pulmonary exacerbation rate in these patients. So if we can prevent pulmonary exacerbations in patients with cystic fibrosis, we hope that we're slowing the damage to the lungs, and hopefully will increase their life expectancy with that. So after the 24-week study was performed, the Progress trial continued this for a total of 2 years, with a primary outcome of looking at change in FEV1 over that time frame. You see FEV1 with the blue line are the folks who were treated with Ivacaftor, Ivacaftor, red line or control. After 2 years, there was a 42% reduction in annual rate of decline of lung function in patients who were treated with Ivacaftor, Ivacaftor. So not only were we decreasing exacerbations, although there was only a modest increase in FEV1, it seems to be helping sustain lung function over time. So this medicine is called Orkambi, approved in 2015 for homozygous delta 508 patients, and in 2018 is approved for patients 2 years old and over and who are homozygous for delta 508 mutation. So with our 2 medications currently, sorry this has changed the size of the formatting here, but we now have 57% of patients with cystic fibrosis, we have a medication that will target CFTR abnormality. But the story continues. A second corrector was developed called Ivacaftor. So they used Ivacaftor with Ivacaftor, the previous potentiator that had been used in the G551D patients, and studied this in patients who are 12-year-olds or over with 2 copies of delta 508 deletion, and followed them for 24 weeks, blue line being treatment group, gray line being the placebo. They did see a little bit more improvement in FEV1 with the Ivacaftor, Ivacaftor treatment group, and a similar reduction in pulmonary exacerbation. But the thing that was really nice about this medication were side effect profile. The Orkambi or the Ivacaftor, Ivacaftor caused a lot of chest tightness and wheezing, so many patients couldn't tolerate being on treatment. This did not have that type of side effect. And additionally, the Orkambi or the Ivacaftor, Ivacaftor had lots of drug-drug interactions because of metabolizing through the liver. So SSRIs had to be adjusted. Many of our antibiotic therapies had to be adjusted in these patients, making care of the patients on Orkambi more difficult. This new compound did not have those drug-drug interactions. So it made it a more attractive medicine for side effect as well as management of long-term complications of cystic fibrosis. But they also study this medication in patients who have 12-year-old or over, 1 copy of delta 508 deletion with a residual function mutation. Residual function mutations are the ones that were responsive, essentially the ones that are responsive to Ivacaftor from the G551D study. And they found even if you just have one copy of Delta 508 with residual function, comparing placebo to Ivacaftor alone in the combination medicine, you increase FEV1 from 4.7% in the Ivacaftor alone group to almost 7% in the combination therapy. So it's improved lung function with the combination medicine. And with this, the FDA approved this medication. It's called Symdeko in 2018 for 12-year-old and over who are homozygous for Delta 508 or heterozygous for Delta 508 with a residual function mutation. And we're expecting soon this to be approved for 6 years old and over. So now we've moved our pie chart a little bit. A pie chart to cover our homozygous and our heterozygous that have residual function. The actual percentage of patients didn't change drastically, but what did change is the fact that we have a medicine that improved FEV1 over Ivacaftor alone in patients who have these responsive mutations to Ivacaftor, Ivacaftor. So to summarize the three current medications that are available, we have Ivacaftor for 1 year old and over that have one of the 38 responsive mutations. We have Lumacaftor, Ivacaftor for 2 years old and over for homozygous Delta 508 mutation. We have Ivacaftor, Ivacaftor for 12-year-old and over who are homozygous for Delta 508 or heterozygous for Delta 508 with a residual function mutation. Okay, so we have therapies that are being implemented in over 50% of patients who are pediatric patients with cystic fibrosis that have responsive mutations. But we're not where we want to be yet. Although these two medicines, Lumacaftor, Ivacaftor, work well, they don't work for patients who have a single copy of Delta 508 with a minimal function mutation. Minimal function meaning that they don't make protein. So we needed to look further. And this brings us to the next generation of CFTR modulators. I almost feel like Steve Jobs here, you know, next generation of the iPhone or something like that. These compounds are currently just finished phase 3 trials, but we have some data on these compounds, which is very promising. The two compounds that are being studied are the VX659 and the VX445. Most of the data I'm going to show is the 659 because that's what's been published so far. What we see in this is phase 1 trial where they took, in the blue slides, human bronchoepithelial cells and measured chloride transport in patients with this triple combination therapy that has VX659 plus the Ivacaftor, Ivacaftor. And when compared to controls, chloride transport compared to controls, there's a dramatic increase in chloride transport with this triple combination that you don't see with other combinations of the compounds, excuse me. So this is in patients with homozygous Delta 508 deletion. So if you're homozygous Delta 508, you have a very robust response with chloride transport in culture. They also took heterozygous human bronchoepithelial cells from heterozygous patients, Delta 508, with a minimal function mutation. And again, control is black here, minimal chloride transport. The triple combination had robust response. So very promising data that this could be a potential therapy for patients with heterozygous minimal function mutations. So what are the minimal function mutations? So get your pens out, this is more to remember. So the nonsense mutations are listed here. You have canonical splice mutations. There's more. you have small insertion deletions with frame shifts, and you have large insertion deletions with frame shifts. So the alphabet soup is growing for care of these patients. So they took this compound, triple combination compound, to phase 2 trial, and they studied it in both the homozygous delta 508 as well as the heterozygous delta 508 with minimal function. And you see on the left graph here is the homozygous delta 508 looking at triple combination therapy in blue as compared to Ivacaftor, Ivacaftor. And they found after the month trial, there was about a 10% increase in FEV1 in these patients. Now remember, Ivacaftor, Ivacaftor already increased FEV1 based to control of around 4%. So somewhere around probably 14% if we were to comparing this to control for responsiveness to the triple combination therapy in the homozygous delta 508. The right graph here shows the heterozygous delta 508 minimal function studied at 29 days, looking at various doses of the triple combination therapy versus placebo. And they saw about a 13% increase in FEV1 as compared to placebo with the high-dose triple combination therapy. So these compounds were taken to phase 3 study. And in November of 2018, the company Vertex, who developed these compounds and sponsoring the study, showed from an interim analysis that the 659, Ivacaftor, Ivacaftor for the homozygous delta 508 continue to show this increase in FEV1, as well as the triple combination therapy and the heterozygous minimal function continue to show increase in FEV1 as compared to placebo. They didn't report side effects, but they said that they were favorable and felt that this is a good candidate medication to be submitted to the FDA for rapid approval for treatment of both homozygous as well as heterozygous minimal function CF mutations. But they also have this second compound that's being studied that they have finished recruitment, and we're expecting data from that. So one of these two triple combination therapies will be submitted. Which one, we don't know yet, but I think that this is going to be extremely exciting because probably by the end of this year or beginning of next year, we're going to have a therapy for 90% of patients with cystic fibrosis that targets their underlying mutation. This is remarkable. Think back, 2012, we had 0 therapies to treat CFTR mutation. Now we potentially have 4 that will cover 90% of patients with cystic fibrosis. And if we can start these therapies as children, you can only imagine how this is going to change people's lives. But we're not there yet. We're not at the 100%. And unfortunately, these 2 last pieces of the pie are going to be a true challenge. But I think the dreamers of the day here can help us move this forward. Where we're running into challenge are the rare mutations. Rare mutations mean that there's maybe 2 to 4 patients in the world with these mutations. So there's not going to be any large clinical trials. So how are we going to determine response to therapy? Probably going to have to use stereotyping, where you take human bronchial epithelial cells and you screen compounds to find responsiveness to chloride secretion and give them these medications and see what happens to them. The second piece of the pie that's going to be a challenge will be the class 1 mutations where there's no protein made at all. So this is going to be gene therapy, mRNA therapy, or even read-through compounds that force translation of protein. Big hurdles to jump, but I think that the progress that we've made in the past 7 to 8 years, these are real possibilities to be seen in my lifetime as a CF doctor. So in summary, there's been rapid advancements of treatment of CFTR mutations based on class. These modulators increase FEV1 and decrease exacerbations. And we expect this to increase life expectancy in our patients. So as this life expectancy increases, and it was reported at the 2017 CF conference, the average life expectancy of a CF patient in 2017 is 45 in the United States. We're thinking about, wow, they're adults now. What do we do with things like colon cancer screening? Recently put out guidelines for colon cancer screening for CF patients. I would never have thought of that when I was in medical school. Amazing. But what do we do with these other things that patients develop as they get older and that you're going to be seeing in your clinics? Because we're going to need your help managing long-term complications as patients age. I think this is a rich area for research for people who are interested in trying to answer some of these questions because nobody's ever had this challenge before. So as I finish today, I'd like to just tell you a little bit about our CF program here at Wake Forest, a little bit of shameless self-promotion. It really takes a team. So this is our numbers here at the CF Center. Blue is the pediatric center, gray is the adult center. And you see since 2008 to 2017 that we've had a steady increase in the adult patient population in our center. And actually, over the past year, we've we've transitioned an additional 6 patients from the pediatric center and have acquired about 4 patients from outside facilities. So we're somewhere around 70 patients in our CF center. To give you an idea, that's considered a moderate to large size program. Together, our numbers are a large program, over 100. Now, as you saw all of these different mutations, and we didn't go into all of the kind of standard of care of cystic fibrosis, but it's complex. So every week before CF clinic, 4 days before, we run through a checklist to help us make sure that we're following treatment guidelines for our patients. Review their genetics, review their medications, labs, BMI, and we come up with a multifaceted plan of care to address any outstanding issues that we will need to in their visit. And a major area of emphasis in CF world right now is mental health screening and mental health care for our patients with these chronic diseases. So we prioritize this as well in the past year. So how do we stack up against the national averages? So Wake Forest is this column here. There are 4 metrics that the CF Foundation makes available online. They look at lung function, nutritional status, CF-related diabetes screening, and adherence to guidelines of adult care. Wake Forest is at or above all of our metrics except for CF-related diabetes screening, which we've made a intentional focus over the past year. So I'm anxiously awaiting the 2018 data to see where we stand. I expect this to be at least at the national average in our next round. So compared to the national average, we're doing well here. We have a very strong program. What about looking at the regional and national programs here? We look at UNC Chapel Hill and Duke. We're at least on par, if not above, in many of the metrics that they look at that is reported from the CF Foundation. And we're similar to the major kind of forefront leaders in CF care, such as Johns Hopkins and the National Jewish Hospital, and many of our metrics as well. So I think we're doing a great job here, and this really could not occur without a great team of people helping care for these patients. It's a multidisciplinary team that includes nutritionists, nurse coordinators, respiratory therapists, social workers, psychiatrists, research coordinators, and all of you, to help us take care of these patients when they come into the hospital with complications and things. And you're part of our team, and we thank you all for helping us care for these patients and helping them live long, productive lives. So thank you for your attention. I'm happy to answer any questions that you may have. And again, thank you all for helping us care for our patients.
Open up the floor for questions. Dr. Hazard.
This is fascinating in every dimension, intellectually and historically and so forth. I'd be interested in your current summary of how you approach the issue of ethics, and especially giving advice to parents of young people with this disease.
Yeah, so really, I think what your question is going, so the question essentially, for those who may have not heard well, is essentially family planning, I think is where you're going. Family planning, now that patients are living longer, and we actually recently have had a couple of conversations with patients in our clinic about family planning. Initially we address with them the fact that this is a genetic disease. We work closely with the geneticist here at the hospital. Tara Stamper is somebody we work very closely with, and we encourage all of our patients to go speak with Tara to help map out any genetic counseling and testing that they may need to do beforehand. Some of them wish to undergo that. Others wish not to go undergo that screening process, and we ultimately leave it up to them. But we do have resources available to them, and it's a very important part of care for those folks who are ready to make families.
Chad, that was absolutely fantastic. Actually, I had two questions. One is about heterozygotes. So about 4% of the population are heterozygote. Are there any deleterious effects in pure heterozygotes, or on the contrary, are there any survival advantages for being a heterozygote in certain situations? And then the other question I had is so the therapeutic development story is an amazing one for cystic fibrosis. But many of the costs of these medications are substantial. I was wondering if you could address some of the cost issues and what current policies of insurers are related to coverage for these medications.
Sure. So I'll tackle the second question first, with regards to. So the question essentially regards to cost of medication and insurance coverage. So a large proportion of patients with cystic fibrosis are on Medicaid. And with that, as long as they have the genetic testing saying that they have a responsive disease, they have access to medication. The Symdeko cost about $300,000 a year right now. The Orkambi, actually the first generation combination medicine is even more expensive than that. So with the new medicine, they seem to be trying to drive down the price. Those who do not have insurance or have access to medication, the drug company actually gives them the medicine, provides it to them free. So the CF Foundation as well as Vertex, I think, really want access to these medicines for these patients and work very closely with the insurance companies to be able to get that provided for them. With regards to folks who are carriers, which I think essentially are carriers of disease, I don't know much about any deleterious effects in these patients. Since it's a recessive disease, your phenotype will be based on your least deleterious genetic abnormality that you have. So if you have a delta 508 and then your second copy of CFTR is normal, your phenotype should be a normal phenotype. Are there outliers to that due to epigenetics as well as maybe, I still think there's probably at least in some patients with CF that have some type of protective gene, because we have delta 508 patients that have never been on dual therapy with Orkambi or Symdeko that have great lung function for some reason and do not exacerbate. So there's very complex other things happening genetically that we don't understand yet. But I think that these are areas of that would be very interesting to study. So I don't know personally. There may be folks out there that do know the answer to those questions.
Thanks, Chad. I was wondering about the potentiator medications and what they actually do to CFTR. Do they make the channel open all the time, and is that why there are side effects in a subset of patients that tend to have wheezing, sort of like we see in hypertonic saline with some patients, or what your thoughts are about that?
So the question deals with really the mechanism of the potentiators and how it functions. The binding of these potentiators, I don't know the binding mechanics off the top of my head, but as long as it's binding to the protein, it should be opening the channel. Most of the Ivacaftor potentiator therapy in and of itself, when we're treating these residual function mutations, pretty minimal side effects. It's really the dual therapy, the Lumacaftor, Ivacaftor, where we were treating the homozygous Delta 508 patients that had the wheezing and chest tightness. So I don't know why in those specific patients, it may be an interaction between the Ivacaftor and the Lumacaftor, or maybe the Lumacaftor side effect itself. But I don't know of anything specific about the Ivacaftor that would be causing the wheezing.
Any other questions? Dr. Petty?
Yeah, so one of the things we struggle with sometimes in oncology is when we have drugs that clearly work, it's hard to prove an overall survival advantage because you see these clear evidences of activity, the drugs get approved, they're available to everyone, and the survival benefit sort of washes out the clinical trials. The ones that I've seen so far don't look like they're going to answer the question as far as a true overall survival advantage for the population. Are you aware of any that are going to be able to prove that? How are we going to know 10 years from now if these drugs really impact survival?
So I think it's going to be hard to answer that question because in addition to these medications, there are various other medications in the pipeline. I don't have the slide. There are currently in the therapeutic channels probably, I would say off the top of my head, 20 or plus medications that are currently being studied for various aspects of respiratory disease and CF. So to be able to say these medicines in and of themselves adds a survival advantage, I think will be difficult to answer. But as these medicines become generic and hopefully patients are living longer and longer, we could potentially entertain, this is not recommended by the CF Foundation yet, but recommend decreasing some of the other therapies and see how patients do with just these specific therapies targeting CFTR. So other therapies like the hypertonic salines and the DNases inhaled and other types of chronic management therapies that we currently use in CF. And I think that would be the only way that we'd be able to really answer those questions. Now, would anybody be willing to do a trial on that and pull those things away? I mean, I would think it would be probably a hard sell.
The way discontinuation therapy kind of evolved in CML, for example, where the TKIs have been very effective, is patients did it. There are subgroups of patients that just were non-compliant, and we learned from them. There are subgroups of patients that just couldn't afford it, and we learned from them. And so people didn't extrapolate and start developing clinical trials. So we thought people would be on those for the rest of their life, but by happenstance and observing and collecting those data as we go, so prospectively collecting that data may actually give people the confidence to do the trial down the road just by happenstance.
Yeah, and you know, that's the great thing about the CF registry data. We capture all the patients that are on therapy, and since there's currently one company that provides these medications, they know which patients that are actually filling their prescriptions. So we have good compliance data based on that. I think that we'll probably, I agree with you. There are actually several patients that come in clinic saying, hey, when can I get off these medicines? And are they doing their other therapies at home? I don't know for sure. I mean, it's all self-report at this point. But I agree with you that that's probably going to be one way of doing it. The addition of the other therapies will complicate the answer to the question, though.
Any other questions for Dr. Marion? All right. Well, thank you so much.
Thank you all.
Don't forget to fill out your evaluation forms, please.